So I guess we'll get started for this evening. Thank you so much, everyone, for coming to this evening's webinar hosted by Liver Canada on traveling with liver disease and protecting yourself against hepatitis A. My name is Ashley Lawrence, and I'm the host and the moderator for the webinar this evening. So just before we get started, a reminder to keep yourself on mute for the remainder of the webinar. And if you do have any questions along the way, just to please drop them in the chat. And then at the end, we have a designated time for a Q&A if time remains at the end of the session. So Liver Canada is located on the traditional territories of the Anishinaabe and the Haudenosaunee Mississaugas and Mississaugas of the Credit First Nation. And we'd like to acknowledge and extend our gratitude and respect to all First Nations, Inuit, and Métis people for their valuable contributions. For those of you who may not be super familiar with Liver Canada was first established in 1969, and it was the first organization in the world created to help people with liver disease. So we are committed to promoting liver health and improving the prevention, the diagnosis, and the treatment of liver disease in Canada through funding different research projects, our education programs, our patient support program, and advocating for different liver health policies as well. So joining us today is Dr. Fernanda Onofrio, and Dr. Fernanda Onofrio is a staff hepatologist at Toronto Centre for Liver Disease, Francis Family Liver Disease Clinic, and specializes in the care of patients with alcohol-related liver disease, MASLD, cirrhosis, and its complications. So thank you so much, Fernanda, for joining us this evening. Just an agenda before we jump into Dr. Fernanda's presentation. I kind of just went into a brief introduction, and I'm going to launch a few poll questions just to get an idea of everyone's current knowledge on the subject we're covering today. And then Dr. Fernanda will do her presentation, and then a final poll at the end just to gain your feedback on the webinar. And then if time we still have time, then we'll have the Q&A portion where you guys can ask questions and Dr. Fernanda can answer them for you as well. So I'm going to launch those initial poll questions first, and I'll give you a few minutes. Is everyone able to see the poll questions?
Yes.
Okay, great.
We just have to get the QR code. Is that how it works?
Nope, it should come up on your screen, so you can just answer it on the screen. It's like a little quiz. Perfect. I see some people responding. Give it just like 30 more seconds.
Is my audio working okay?
Yep, we can hear you.
Okay, thank you.
Perfect. So thank you so much for participating in the polls. I'm going to end them now. So Dr. Fernanda, I invite you to now share your slides and give the presentation for this evening. Thank you so much.
See if I can share screen 2. Share. Are you guys able to see?
It's just loading. There we go. Yep. Perfect.
Perfect. So thank you, Ashley, for inviting me to talk with people and patients in general who are interested in learning a bit more about liver health and how to prevent disease, I think the best way is always prevent rather than treat once the disease is already established, right? So let me see if it works. So we're going to talk a bit about the hepatitis A and a bit about how to prevent decompensation of chronic liver disease while traveling. Let's see how I pass my lines. So I have no conflicts of interest for this talk in particular. This is what we're going to discuss as I just told you guys. So to start off, I wanted to kind of bring to a bit more practical in terms of real life, other than just stay in the theory. So I brought a case, and that's usually what we do when we teach the medical students and the residents here at the hospital, the university. So this is a 25-year-old woman that came to the clinic with a history of yellow eyes, yellow skin. There's a music there. Yellow skin, complaining of feeling extremely tired, lack of appetite. She was also complaining of a bit of discomfort in the upper right side of her abdomen. She told us that the symptoms started a few days after she developed vomiting and diarrhea, and those have resolved, but then she developed the fatigue. And she told us that she had a recent travel to the Dominican Republic. And then that's a picture just to illustrate how the yellow eyes that we call jaundice looks in the patient. Right, so we can go back to this case at the end to kind of summarize what she was presenting here. So just to give some idea of what is a viral hepatitis, it's any infection that causes liver inflammation caused by a virus. It can be self-limited or it can progress to a chronic liver disease. We have 6 types of hepatitis, of viral hepatitis, but the ones that cause damage to humans are the hepatitis A, B, C, D, and E. The hepatitis A and E, they are typically caused by ingestion of contaminated food or water. And that's how I tell the med students when they are learning, like to memorize the vowels. The hepatitis with vowels are the ones that are caused by contaminated food or water. And the consonants, the hepatitis B, C, and D, they are the ones that are usually caused by a result of parenteral contact with infected blood or body fluids. The hepatitis B and C are the most common cause of chronic viral hepatitis. So those are the infections that can cause cirrhosis of the liver. Hepatitis A and hepatitis E do not cause chronic infection. They do not cause cirrhosis. And hepatitis B is very rare. It happens in the specific areas in the world, in specific countries, but and they only happen in patients with hepatitis B. So the hepatitis D virus needs the B to co-infect the cell. So it's not possible for you to have hepatitis D without having hepatitis B. But let's focus on hepatitis A, which is the main topic of the talk today. Just to give some background, this is an RNA virus, different from, for example, hepatitis B, which is a DNA virus. This is an RNA virus, and it causes an infection that usually is mild, but a very small part of the portion of the patients can develop severe and life-threatening hepatitis. So that's what I usually tell patients. Either you have very mild, you not even notice you have hepatitis A, especially when you are a child, or you can acquire that as an adult, and then you can develop like severe fulminant hepatitis and sometimes even requiring liver transplant. So it's as I told you before, it's an acute infection, and the main issue with that is that if you acquire as an adult, especially in the elderly, above the age, I would say 65, then the risks of the disease to become more serious is higher. And 25% of patients who acquire as an adult will require hospitalization because they feel really unwell. They have jaundice, they have abnormal liver tests, they can progress to liver failure. And the main issue with the patients so far that I had with that acquired hepatitis A in an adult phase was the fatigue, the symptoms. So they had mild jaundice, the liver enzymes were high. Slowly they improved, but they persisted with fatigue. They were severely exhausted and complaining of being super tired because of the infection. That can take like usually on average 3 months, but go can last longer. Again, it does not become chronic. The good news is that there is a safe and effective vaccine that's available to all the patients that have chronic liver disease. For healthy individuals without any liver disease, then it's not covered by OHIP. The transmission of hepatitis A occurs through stool, so through feces of infected individuals, by ingesting contaminated water or food, or through the direct contact with an infectious person. It's what you call fecal-oral transmission. So if you eat, especially when patients travel and they eat seafood like raw oysters or shellfish that was like harvested from contaminated water, we had reported cases of patients who acquired hepatitis A from buying from supermarket like frozen berries, like blueberries, strawberries, like frozen to do smoothies and other things, and then probably the person who prepared and bought and placed the fruits in the package was dealing with the fruits without the proper hygiene, um, uh, and then transmitted the disease. Also in vegetables and those ready to eat food. So for my patients, I usually tell them in terms of nutrition, cook your own food or only eat in places that you know that things are done with good hygiene, and avoid like sometimes like these places that are a bit suspicious in terms of hygiene. The life cycle of hepatitis A starts when we ingest, so the contaminated food or water, and then it navigates through the bloodstream through the oropharynx, so where we swallow, right? And then to the intestines, and then it is attracted to the liver, so it reaches the liver, it enters the liver cell, the hepatocyte, and there it replicates and it's secreted in the bile because the liver produces the bile. So it's secreted into the bile and then it's released to the stools. There is just a schematic picture of the tiny virus entering the liver cell and then being secreted in the bile. Is there a geographic distribution for hepatitis A? And the answer is yes. It's an infection that is common in low and middle income countries with poor sanitary conditions and hygienic practices. The epidemics, like outbreaks or epidemics, are a bit uncommon because teenagers and older children and adults are generally immune. So most of the times we acquire hepatitis A as when we are children, when we are in daycare and school, because we share like saliva and food and drinks and everything. And usually it's just a mild like virus infection that nobody even thinks about hepatitis A. And then when we see patients for other reasons when they are older, and then we check the hepatitis A immunoglobulin G, that is the hallmark of the disease, of the contact exposure to the virus, then we see that the patient is positive, and the patient's like, oh, I have the infection now. And then we tell them, no, either you were vaccinated by the hepatitis A or you were exposed to the virus at some point in your life, and now you are protected. So most of the children, 90%, who have been infected with hepatitis A before the age of 10 years. As I told you, outbreaks are rare. And then the literature and then says that Africa and South Asia are the greatest hepatitis A, have the greatest hepatitis A burdens. In high income countries, the infection rates are low. However, we do have high risk groups. So what are the high risk groups that could potentially be infected easily from hepatitis B? So people who work with healthcare and manipulate samples and all material from patients infected. Patients that like homeless because of live in the streets, so they have poor hygiene. People who inject or use substances, men who have sex with men because of the anal practice, then you can have exposed to stools or contact with the stools. International travelers, so traveling to low income or middle income countries where the hepatitis A is endemic. And then immunosuppressed patients, such as patients living with HIV and patients living with chronic liver disease. So if you already have other liver disease, such as other types of viral hepatitis, the chronic viral hepatitis, or cirrhosis caused by any specific etiology, or fatty liver disease that we call hepatic steatosis, or most recently the name of the fatty liver disease now is the steatotic liver disease, or metabolic associated associated steatotic liver disease, alcohol liver disease, and patients with other types of liver disease, including autoimmune hepatitis. What are the symptoms of hepatitis A? So in children, asymptomatic or just a minor cold, or like it's usually it usually pass by undetected. The symptoms are much more common in adults, and usually the patient will complain of fever, malaise, loss of appetite, can have some diarrhea, some nausea, some abdominal discomfort, usually in the right upper quadrant of the abdomen where the liver is located, because the inflammation distends the glycan capsule that involves the liver, and that can cause some discomfort. It also can make the urine very dark and show the jaundice, so the yellow sclera, right? We call scleroicterus, or the skin being yellow. In older patients, as I mentioned, there is an increased risk of worsening of worse outcomes, including requiring hospitalization because patients cannot eat, they vomit, they feel unwell, and so they require IV fluids, they require monitoring of the liver function, and sometimes they require transplant. The risk of relapse is very low, but as I told you, the symptoms, the malaise, the fatigue can be prolonged as long as like 6 months. I had one patient that 1 year after the hepatitis A, she was still complaining of fatigue. How do we diagnose hepatitis A? It's simple. It's a blood test. You usually suspect by the history, as we saw the clinical case in the first slide. We just check for the hepatitis A virus, so HAV, and then we check the immunoglobulin M, that means acute infection, and the immunoglobulin G, to check for either if it's positive, if the patient is vaccinated, or if the patient was exposed to the virus at some point in their life. So that would also be positive. The virus is excreted 11 days prior to the appearance of the symptoms or the appearance of the hepatitis A immunoglobulin IgM in the blood. The incubation period varies, but it can go from like 2 weeks to almost 2 months. And the virus disappears, the IgM, within 4 months, but sometimes it may persist longer in the blood. So this is the graphic that we usually show the students. We show that, so it's the weeks compared to the concentration of hepatitis A. So in the yellow, you see that in the first weeks, the virus in the blood, so viremia is the concentration of virus in the blood. So the virus in the blood is high. The virus in the stools is super high, is the black in the first weeks. Then it trends down it's not transmissible after, I would say, 5 to 6 weeks. The liver enzymes in the purple, the ALT is super high in the beginning, then it trends down. And then immunoglobulin M that slowly grows, the immunoglobulin M that has a fast increase, then it slowly drops, and then the IgG will slowly develop, and that's going to be the hallmark of the disease. If you had hepatitis A, that you have a long-lasting IgG, and that means you don't need to be vaccinated anymore, because if you got exposed to the virus and you develop the immunity, which means the IgG, then you don't need to be vaccinated because you already develop immunity to it. Treatment. There is no treatment. There's no specific treatment. There's no antiviral that we take for this specific virus. Like we have antiviral for hepatitis C, that we cure hepatitis C. We have antivirals for hepatitis B. We don't cure, but we maintain patients. We have antiviral for HIV, but for hepatitis A virus, there are some studies going on, but there's no specific antiviral for hepatitis A. The treatment is basically supporting the patient. So if the patient's having vomiting, so anti-nausea medication. If the patient's having diarrhea, replace fluids so that the patient does not become dehydrated. Check the kidneys, the renal function to make sure that the patient has enough fluids. And then monitoring the liver function in case the liver function deteriorates and the patient requires like transplant. It's also, I didn't mention here, but it's also more severe in pregnant women because the pregnant women are naturally a bit immunosuppressed. So also it can be a bit more severe during pregnancy. During the acute hepatitis A, we should avoid Tylenol, so avoid acetaminophen, because it can make since it's a drug metabolized by the liver, even small amounts in this phase plus the virus can make it worse, and also should avoid anti-inflammatories. So it's a bit frustrating because we cannot prescribe any specific painkiller for that time. We just have to avoid painkillers. So if a patient is really in pain, then we could potentially give like opioid, like morphine, but we should avoid anti-inflammatory and avoid Tylenol. The risk of death is very low. We should prevent as much as we can, and there are available vaccine. The vaccines are, you receive the first dose day 0 and then 6 months later. Even a single dose is already very protective. Some countries were adopting just a 1-dose vaccine scheme, but the recommended globally is 2 months, is 2 doses with a 6 months interval. It provides long-lasting immunity. It's super effective pre-exposure, right? It's, as I told you, is insured for patients with chronic liver disease. And the most important thing is avoiding the contamination, the transmission through like hand washing, avoiding contaminated food. So we usually recommend boil it, cook it, peel it, or leave it. Avoid also some patients that were swimming in contaminated water, like in lakes, in rivers, and canals, especially after like flooding season or heavy rain. So they can get exposed to the virus, especially if they swim and swallow water, or if they have a open wound or something that they can get contact with the virus. And then avoid contact with patients. So if you have someone with hepatitis A at home, I would say either leave home or separate that person from the house. So they have their own washroom, own towel, everything. Because if you touch in surfaces or things that someone with hepatitis A touched, you can get infected because it's superly transmissible. So you should kind of isolate that person if possible. But if the person living in the home is vaccinated, then it really decreases the chance of transmission. Okay, we're gonna switch to the traveling part. Hopefully I'm still on time. And then we're gonna have questions at the end. So what about traveling with chronic liver disease? So before the travel, the goal is to, again, prevent. So protect your health and avoid complications. And that's done through the pre-travel health assessment. When we should do a pre-travel assessment, the travel medicine guidelines and even the Canadian border orientation is that you do an assessment at least 6 weeks before your travel. Who should do that? All patients with chronic liver disease. With whom they should be assessed, like who is the doctor who would assess these patients? So it can either be a combination of family doctor, the liver specialist, and a specific travel health specialist. But I would say at least the family doctor and the hepatologist. The hepatologist, because we have to assess how the clinical status of the patient, like how safe is for the patient to travel from a liver perspective. But the family doctor would say it's also important because most of the times these patients have other disease. They have high blood pressure, they have diabetes, they have depression or anxiety, so they are on antidepressant medications, or they have asthma. So the other chronic liver disease also should be assessed so that the patient has a safe flight and then is safe during the trip in another country. What we do in an assessment, so usually we assess the demographics, right? Like who is this patient? Is a man, is a woman, it's obese, it's not obese, how old the patient is, will the patient, and then we assess the clinical status, as I told you, of the patient. We check like where are you going? You are going like to do a very adventurous trip. You're gonna go to high altitudes. You're gonna swim. You're gonna practice very risky sports and trails and what, right? Or it's gonna be on like a hotel with all the hygiene and no high risk. Or so we see the vaccination card, the immunization history, and then the severity of liver disease and the risk of decompensation. So in a hepatologist consult pre-travel, usually we review the blood work of the patient. So what's the most recent blood results that we can assess the liver function, how this liver is working. We usually assess 3 things: the bilirubin, the INR, and the albumin. Those are very specific, so nobody needs to remember this, but just we review the blood work. We also check if the abdominal ultrasound is up to date, so to check if there's no clots around the vessels, or in the vessels around the liver, to check if there's no cancer, if there's no water in the belly. We review the medication list, so what the patient is taking. what are the doses. We review if the patient that the patient has to be on low salt diet. If this patient, for example, has cirrhosis with a previous history of water in the belly that we call ascites. So we check if the patient is on water pills, what are the doses of the water pills, if we should continue the same dose during the travel, or we should increase or we should decrease. We also provide enough refills so that the patient does not run out of water pills during the travel. We also check if the patient is vaccinated for hepatitis A and B, because those are super important in someone with chronic liver disease. If you are a patient here from our liver clinic, and I would say most of the hepatologists in theory, that's the first thing that we check in our first visit is the immunization for viral hepatitis. So probably at this point, if the patient is followed in the liver clinic, the patient was already vaccinated with hepatitis A and B. And we also check some destinations require the patients to prove the immunization record to yellow fever, for example, or COVID or influenza, or so. Those are the routine vaccines for age. So like the pneumococcal vaccine to avoid pneumonia after the age of 65, or the seasonal influenza that we have to do every winter or before every winter. So those vaccines would be checked by the family doctor, but here in the liver clinic would focus basically in the viral and the hepatitis A and B for sure, and yellow fever if it's the case. And we can provide a letter summarizing the condition, like this patient has lives with cirrhosis caused by metabolic syndrome. He's currently well compensated on water pills because of a previous history of ascites that is now controlled. So we can, in case of that something happens, then the doctor in the country will see what's going on. There is a bunch of routine vaccines that in the left side, they are to be reviewed by the family doctor, and then in those travel clinics, so the travel doctor usually reviews with the patient the travel vaccines depending according to where the patient is traveling to. For example, as I told you, yellow fever is some countries in South America, and I think Middle Eastern, they may require the proof of vaccination for yellow fever. What is the to-do list for the patient or for the traveler with chronic liver disease? So as I told you, assessment by the family doctor and at least by the family doctor and the liver specialist. They will check for travel insurance, like in case this patient has cirrhosis and has varices in the esophagus, for example, which is a complication of cirrhosis, and suddenly vomits blood out of the country, which hospital is close to the hotel or to the place where the patient is staying. So those are things that ideally should be checked in advance, because when things happen, they are super fast. So you have no idea who to call, where to go. So it's good to know, like, will my travel insurance cover in case I need to go to emergency room in this country or to be admitted to the hospital there? Who can I contact? Do I have any family members or friends in this other country that could support me? And what are the potential doctors that I could see there? Like, is there any liver specialist in this country, or at least a good internist that could provide a first assessment? So we would review the destination recommendations. Sometimes they have this advisory for each country. I'm going to show you the website where they say, please be prepared because this specific destination has this and this issue. I would also bring a medical note just in case. Not that's going to be used, but I would say always prepare. So hope for the best, prepare for the worst. So bring the medical note, the list of medications, the script from the doctor, or just get a copy from the pharmacy. Bring enough the bottles with the names. So don't bring like random bottles without any label. So bring the bottles exactly with the labels, or if patient has a blister pack, for example, for 2 weeks or 3 weeks. I don't know how long the travel will last, but you can bring the blister pack medications, which is a tiny folder that the pharmacy provides. And then when you open, all the medications are in tiny blisters, and then they have like morning, night, everything. Also bring the immunization card if you have one. And then like look up which hospitals are available in case you need medical attention during your trip. This is a useful link in terms of, there is here in Canada, they have this website called travel.gc.ca, and you just type the country that you are going to, and that gives you a list of recommendations. So my home country is Brazil, so I typed Brazil just for fun. And then when I typed the country, they say like the pre-travel vaccines and medications that I should be reviewed or should be protected to. They even describe in some countries, like if you have to prevent from like tick or insect bite prevention, and how to protect yourself. So it's very simple, very detailed, and very simple but very detailed at the same time, in terms that it's easy to read and it's very organized. So that would be my suggestion. During the trip, then, so that was before the travel, and what to do when you are in the middle of the travel, like you are entering the airplane, what you should do. So some patients, if they have severe liver disease, they also recommend to use a medical alert bracelet, like patient with chronic liver disease, for example. Also, we recommend to use compression stockings, because these long flights, I would say any flight above 3 to 4 hours is considered long. So chronic liver disease can increase the risk of clotting, even though we have low platelets. When you have advanced liver disease, even having low platelets, you are still predisposed to develop clots, so deep vein thrombosis, they call DVT. And ideally, we should walk during the flight, stretch. There are some movements that you can do during the flight. But using the compression stocks really helps. I don't have chronic liver disease. I use my compression stocks every flight. Also, stay hydrated during the flight. Nowadays, they you only serve water like once or twice during long flights, so you can have your water bottle after you pass security. So stay hydrated, because of the air and walking and everything during this flights that you have to walk in the airplane for long distance. So we lose water during the flight, because of all the conditions of the airplane, and also by walking. And so I always stay hydrated and eat safely. Those who need to eat low salt. So the problems with the airplane snacks, they are super salty, and that's the goal, because they want to keep the blood pressure high during the flight, not low, like in the high end, not in the lower end. But I would say try to bring their own snacks. I had to bring food for my son, for example, in the flight, because he had many allergies. And with a ladder of the allergies, I could bring, of course, it's not food that will deteriorate fast, but super fast. But so we can still bring some food, some good quality food without salt. And of course, wash the hands, use the alcohol gel, take care of wounds, cuts, avoid like deep massages and tattoo, body piercing, swimming in contaminated water. Had a patient that she had a super strong massage in another country, and then the person who was doing the massage kind of inoculated the bacteria from her own skin to her bloodstream, so she developed cellulitis. So don't do super different things if you have a chronic liver disease. So don't change too much the routine and try different things that can cause harm. Also make sure that don't have any dental issues, because can also develop infection, and dental infection can go to the bloodstream, and then if you have chronic liver disease, that can also cause trouble. Avoid alcohol, so anyone with chronic liver disease should not be drinking. So avoid sugary drinks, because that will cause imbalance to the metabolism, and prefer non-alcoholic drinks. Who is my patient, I always tell alcohol is a toxin, it's a carcinogen, and increases liver damage. So I am against it. When to seek medical attention during your travel. So if you have cirrhosis, if you have advanced liver disease, and you develop confusion, like day-night reversal, which means sleeping the whole day and awake the whole night, or feeling more drowsy, or your partner notices that you are a bit slow in your thought, or you cannot operate your phone or your computer, so things are a bit confusing, that can be a sign that you have hepatic encephalopathy, and that should prompt a visit to the emergency. If you develop jaundice, so yellow eyes, yellow skin, if the urine become dark as coke, like black urine, very dark urine, if the stools, instead of being brown, they become pale, if you vomit blood, that can be from the varices in the esophagus or the stomach, so that should prompt a urgent visit to emergency. If the ascites redevelops or reaccumulates, so if notice that the belly is becoming more distended, usually means more than 5 pounds per week. More than 5 pounds of weight gain in 7 days can represent ascites accumulation, so that can be decompensation of liver disease. If the legs are swollen, the feet, the ankles, and then it starts in the lower limbs, and then it goes up, it progresses in upward direction. Other recommendations for those patients who already decompensated from a liver disease, I would avoid traveling with varices in the esophagus that were recently banded, because sometimes we have post-banding bleeding. So the banding is those elastic bands that we place inside the food channel called the esophagus. And patients with cirrhosis, they have those varicose veins in the esophagus called varices, and those can rupture and bleed. So if you just had a procedure done in your varices, I would avoid traveling, because there is a phase that sometimes patients can bleed. So I would say first completely eradicate your varices and then you travel, because then it's safer that nothing will happen. If you just had an episode of bleeding, then I would also avoid. If you have a big belly full of ascites, that's a risk of leaking, a risk of infection in the fluid. So it also should be avoided. Also avoiding constipation, because patients with cirrhosis, when they get constipated, that can predispose to confusion, to encephalopathy. So try to be hydrated, not more mobile, like in terms of exercising, and eating plenty of fibers, and water, and drinking water to avoid constipation. Can also take the lactulose with you, which is that sweet syrup that nobody likes, but that really helps to have bowel movements and avoid constipation. And then avoid taking anti-inflammatory, ibuprofen, because those can decompensate, can make the liver function worse and increase the risk of bleeding. I think this is the last slide with just a few useful links. So to get more information about the destination that you're going to travel, with the Border and Travel Health. That's the website. If you want some travel advice for specific destinations, those are the other two websites. And then some orientation about vaccines, then is the last website there. Thank you. Let me stop sharing here.
Great. Thank you so much, Fernanda. It was a great presentation. It's definitely an important topic this time of year when everyone's getting around to traveling and going on vacation in the summer. I'm just going to share my slides quickly. Okay, so just before we jump into the Q&A where Fernanda can answer some of your questions, I'm just going to launch the final polls just to gain your feedback on the session. I'll open that for about a minute and then we can jump right into the questions afterwards. Just going to give it 10 more seconds so people can wrap up. Perfect. Thank you so much for participating in those polls. I saw we have some questions in the chat already. So Fernanda, if I could read them out and then you could answer them, if that works for you.
Sure.
Perfect.
So the questions from the chat, right?
Yes.
Okay.
So I see here, do we need to offer Hep A booster if a person needs 2 doses or confirms immunity? How many doses when the booster is recommended?
Yeah, so as I told you, it's only 2 doses are needed total, right? The first dose and then the second dose, which is the booster, you can call that, with 6 months apart. If you miss the 6th dose, for example, I had my vaccine myself for hepatitis A, and then for some reason I missed the date of 6 months mark, so I did with 8 months mark past the first dose. So that's still like if you still can do the vaccine up to 1.5 years after your first dose, and even one dose is already pretty. It's already pretty good in terms of providing immunity to it. I'm not sure if I answered the question.
Yep, I think so. The next one is, what if ascites seems to be under good control? Is travel still not advised?
If the ascites is under control, means that's very small. Like we have grades of ascites in the abdomen, right? We have trace when it's minimal layer of water around the liver. Then we have small when there is like a pocket, but not, for example, it's not enough for us to drain. For example, there is water there, but it's not even enough for us to put a needle and drain because the volume is too small. Then we have medium volume or moderate volume. That's the volume that we start noticing and then we drain. And then the severe when the belly is super distended and then sometimes you cannot even press the belly because the skin is super stretched, right? So I would say if it's severe or moderate, for sure I would avoid traveling. When it's small, When it's trace, I think it's fine. Trace aside, it's like minimal, then it's fine. When it's small, depends. If the person is really like committed to engage in low salt diet, because traveling is like it's super easy to eat to miss the routine, like to skip the routine in terms of diet. So if you're able to maintain a very low salt diet and bring your diuretics, then potentially, but I would not go super far. I would go to a place that I would have access to the healthcare if needed.
Great, thank you. Rick asked me a question. What other webcasts are coming? If you wanted to check out our liver.ca/events, you can see the different events that are coming up. One specifically that may be covering NAFLD, or now called MASLD, is our forums, which cover a bunch of different liver diseases, gives different resources, things like that. I know we are having those in September, and some of them are broadcasted, and we have live sessions as well coming up, so you can see if they're in your area or if you wanted to join the virtual screening as well. For Maria, would you discourage flights of 8 hours?
It depends. It depends the severity of liver disease, how the patient is, right? So if the patient is super healthy, otherwise has no medical issues that can decompensate at any moment, then it's fine. Like you bring your medication, you bring your water, you avoid to be exposed to like suspicious places in terms of eating. And then you have like your travel insurance, so it's supposed to be okay. It depends on how the patient is, right? Sometimes I see patients that are just recompensate, like they've been through a bad period in terms of their liver disease. They had bleeding, they have ascites, and they are just like 1 month stable or two. Then it's hard for us as physicians to say, oh, go ahead, nothing will happen to you, right? If the patient has just improved, so it's still like not fully recompensated. So it depends on how the patient is doing. The only thing that I tell my patients, for example, with varices, it's like if you have a variceal bleeding uh, in a long flight of more than 8 hours, and you bleed when you are up there, right? Until the airplane reach the floor again, the soil again, you can sanguinate, like, because in the flight I already had to help some patients during the flight. Like, is there any doctor on board? And then, okay, I'm there, I'm here. And then there was a patient that we are trying to get a vein and give some fluids, and there's no way to give fluids in the flight. We could only give pills and water and measure the pressure, but then you don't have medication. So if you vomit blood, there's not much that we can offer other than start resuscitation in terms of massage, cardiac massage. Other than that, so I would say it's not easy to come down super fast if you have a bleeding during a flight, right? But if you have a short flight when the airplane is not that high, then potentially you can safely wait a few minutes so that the airplane can come down. But if you're super high until it comes down, then you lost too much blood. So that would be our main concern. Yeah.
Great. Does anyone else have any questions for Dr. Fernanda? If you guys have any questions, feel free to reach out to us at Liver Canada as well. We have a great patient support team, and we have a bunch of different resources we can send. So if you think of anything after the session, please feel free to reach out to us. I think Rick has a question about NAFLD. Can he ask that to you quickly?
Sure. If
A few
we have
extra
time,
minutes?
Yeah, for sure.
We have a few extra minutes here.
Feel free to open your camera, your microphone if you want to.
He says best websites regarding what I can eat and what I should for sure not be eating.
So the ones that I like a lot, so liver.ca I like. So you look for your liver disease there, and then they have recommendation according to each liver disease. The other website that I really like is a website called wellnesstoolbox.ca. It's a website done from the University of Alberta that's super complete. So wellness tool, Tool, box, box.ca. And then if you open the website, it says cirrhosis, and then it explains what you should eat, what you should avoid. They have the most complete guide in terms of diet, of nutrition. It says nutrition guide for patients with cirrhosis. Another website that's also super good is Cirrhosis Care. I think that's the one, Cirrhosis Care or Liver Care.ca. And those explain exactly what to eat, what to avoid, but basically someone with MASLD should avoid sugar in all forms, but mainly the processed forms, like the high processed food, ultra processed food, and too much carbs. And usually the recommended diet is the Mediterranean diet, or the Mediterranean style, which is proteins, beans, whole grains, nuts, and avoiding, as I told you, too much sugar, because sugar in the liver will become fat. Cirrhosiscare.ca, there you go. Yeah.
Great, thank you. Just to wrap things up here, I just wanted to show this slide just to encourage everyone to stay connected. Follow us on our different social media platforms on both Facebook and Instagram at liver.ca. We're always posting the most up-to-date information, different research that's happening in Canada, resources, even our events that are happening and that we're hosting. And then if you also wanted to visit our website, we have a bunch of different resources. Again, you could see the events we're hosting and upcoming things happening at Liver Canada. So just plugging that in there. And thank you again for coming to this evening's event. Thank you, Dr. Fernanda, again for all the time and effort and sharing all your knowledge here with everyone at the event. And I hope everyone has a great and safe evening. Yeah, thank you so much.
everybody. Thank you for coming. Bye-bye.
Thanks. It was very good.